Now, if we look at the situation here compared to normal values, we find that peak velocity, very high. Minute distance, very high. This is a hyperdynamic circulation. But as soon as we look at these four figures at the bottom, the situation's immediately obvious. We have a very high stroke volume, cardiac output of 12 litres per minute, cardiac index 6.9, and an SVR of just 424. It would be a very strange embolus indeed that allowed 12 litres of blood per minute to flow past it. Clearly, the problem that's causing the hypotension is this. She is vasodilated, and despite trying to maintain a very high cardiac output, she cannot maintain normal blood pressure against this kind of vascular resistance. So, when we went back on closer clinical examination, we found what we were looking for, a patch of cellulitis on the upper inner right thigh with small ischemic areas within. She had an inguinal lymphadenopathy on the right side, which explained the edema. What was the diagnosis? Well, by now, I'm sure you're all saying septicemia. No question. The patient was treated with antibiotics, some IV fluids, and noradrenaline, or norepinephrine if you prefer. Her blood pressure increased within 30 minutes to a normal level, and the patient regained full consciousness. We were then able to obtain the history that the patch on the thigh had appeared one day earlier like an insect bite. It had increased in size overnight. She had intended to see her family physician later that day, but had not felt well enough to go to work, so had gone to bed instead. She woke up in the ED. Over the next 36 hours, her temperature settled. She required some vasopressor infusion for 18 hours. But note, she needed only 2 litres of fluid in the first 2 hours and only 3 litres over the next 24 hours. How often have we seen litre after litre after litre of fluid poured into septic patients in an attempt to raise their blood pressure? But their blood pressure didn't respond to it. Why not? Well, Starling told us why not. These patients actually have severe myocardial depression when they're septic. This patient required supplementary oxygen for a couple of days until the readings stabilized, and ultimately underwent skin grafting of the lesion for necrotizing cellulitis. Ultimately, the infection was confirmed as streptococcus in both wound swabs and blood culture. Let's have a look at a third case, and this is the kind of case, I'm sure, where our blood runs cold when we hear it. A 6-year-old child struck by a car brought in with multiple trauma. She was conscious, GCS of 13, but she was clinically shocked. Hypotensive, tachycardic, tachypneic, oxygen saturation was low even on oxygen. But her injuries were pretty gross. Fractured pelvis, fractured femur, fractured humerus, radius, ulna. On the right side of her chest, she had 4 rib fractures, along with significant bruising, scalp laceration, lacerations all over the place. There was bruising on the right upper abdomen, and the abdomen was tender and guarding. She was in severe pain. At the scene, she was given 1 litre of Hartmann solution, or lactated Ringer solution if you prefer. On arrival in ED, she was given 1 litre of normal saline and 500 ml of gelifusine, a plasma substitute, along with 2 units of packed red cells. She was also given morphine, 4 milligrams, followed after 30 minutes by a further small dose. These are her observations after 45 minutes. Now, you can see these for yourself, but the child still felt cold and a little clammy. The question I would ask you, is the patient adequately volume resuscitated? Now, we've all been in that situation of, do we need more fluid? Have we given too much? Are we about right? It's a difficult decision sometimes in children and very difficult in trauma. So, let's have a look at the hemodynamics. Well, let's look at these in a little more detail. And again, let's look at the normal values for a child of this age. Well, we can see her peak velocity is actually quite good. If anything, it's a little high. She is actually hyperdynamic, not normodynamic or hypodynamic. Her stroke volume, well, her stroke volume, yes, that's good. And according to Starling, that must mean her preload is good, her filling is good. The cardiac output, cardiac index, yes, both good. Her SVR is, if anything, a little low. She's actually slightly vasodilated, but she's certainly not vasoconstricted. Now, the peak ejection velocity increases with fluid loading, like Starling said. So a high peak ejection velocity suggests that there is excessive fluid loading. Her minute distance at 33 meters per minute is also high. And again, that suggests excessive fluid loading and vasodilation. Stroke volume, yes, she's well filled. Cardiac index, cardiac output, again indicate good volume filling. Her SVR shows vasodilation. Could that be due to the morphine? She's certainly not vasoconstricted. So although the potential exists with these injuries for major blood loss to occur, in fact the patient is now hypervolemic rather than hypovolemic. When the patient was catheterized, the urine output exceeded 3 mils per kilo for the next few hours. And over the next 24 hours, she needed just 750 mils of crystalloid and only 1 further unit of red cell concentrate. And this resulted in normal hemodynamics and urine output. The following day, a hematocrit was 0.41 and a hemoglobin was entirely normal. Now remember that right lung with the broken ribs and the bruising? That showed patchy contusion on the X-ray, but no major opacification. Would that have been the case if we had over-transfused this child, particularly if we'd used large volumes of crystalloid? Well, we'll never really know for sure, but I think we've all been there in the past and seen a lung like this go white. This lung did not go white. The child needed a little supplementary oxygen, but she did not need ventilatory support. And although she was with us for something like 3 months, she ultimately made a full recovery. A very difficult clinical situation. Resuscitation controlled precisely with no guesswork. One last clinical case. This is a 6-year-old girl. She's miserable and irritable. She's not eating. She's vomited a couple of times. She's feeling hot and sweaty. And she was given promethazine by her local doctor. She becomes drowsy and she develops a macular rash on the trunk, arms and legs. On admission, her blood pressure is a little low perhaps. The pulse, well, that's okay. Temperature is somewhat raised. A little tachypnea maybe. Saturations are good. There is a widespread rash and there is some question whether this is blanching on pressure or not. Well, an urgent USCOM is requested as a possible case of meningococcemia. I think we'd all agree that's a fair call. But when we look at her USCOM tracing, this is what we find.